Welcome everyone to Alan Hu Foundation Mental Health Lecture Series. I'm Qi Hu, co-founder of Alan Hu Foundation and host for your webinar. Today, Dr. Esme Shaller will present an introduction to dialectical behavior therapy for adolescents and young adults. We'd like to thank Three Valleys Community Foundation for funding this webinar. We'd also like to thank Mental Health Association for Chinese Communities for providing simultaneous Chinese interpretation. And thank you to Ida Xiao for Chinese interpretation. And thank you to Marty Dickinson for Spanish interpretation. Alan Hu Foundation's mission is to promote mental health, raise awareness, and remove stigma surrounding psychiatric disorders, and support fundamental research for cures. Please consider making a gift to Alan Hu Foundation by using the donation link in the chat box. Thank you for supporting our programs. Today, it is our great honor and privilege to introduce Dr. Esme Shaller. Dr. Shaller is a clinical professor in the Department of Psychiatry and Behavioral Sciences at UCSF, which she joined in 2007. At UCSF, she helped build the Wavefront Dialectical Behavior Therapy Clinic, for which she serves as clinical director. Both Dr. Shaller and the Wavefront DBT Clinic are certified by DBT Lingham Board of Certification. She's a past president of the International Society for the Improvement and Teaching of DBT. She recently published her first book, Therapy Interfering Behavior in DBT. Dr. Shaller's central passions are teaching and the dissemination of DBT, particularly for adolescents and families. She devotes most of her time to teaching and training, both within UCSF's residency and the fellowship programs, and across California and the United States. She has worked with other members of Wavefront team to implement comprehensive DBT for low-income teens in 3 Bay Area counties. Dr. Shaller received her bachelor's degree in psychology with highest honors from UC Berkeley and her doctorate in clinical psychology from the State University of New York, Stony Brook. In today's talk, Dr. Shaller will present a basic overview of DBT, a type of a talk therapy for people who experience intense emotions. DBT is an empirically supported treatment for suicidal behavior, self-harm, and emotional dysregulation. She will discuss considerations for referral and ways to find cure for the young person in your life who struggles with strong emotions. This webinar is being recorded. Recordings will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. Following the presentation, there will be a Q&A session. Please use the Zoom Q&A function to submit your questions. The presentation is for educational purposes only and is not intended for medical diagnosis. If you have any persistent symptoms, please seek professional help. With that, I'm turning to Dr. Shaller. Welcome, Dr. Shaller.
Thank you so much, Qicheng. I'm so honored to be here, and thank you to you and Xiaofang for reaching out. And welcome, everybody. I'm happy to talk about DBT. It's one of my favorite things. So I'm going to dive in and do it. And I have a tendency to speak quickly, and I'm going to work very hard for my lovely interpreters, Ida and Marty, to not do that. But if I need to slow down, please don't hesitate to let me know. So a lot of people have heard of DBT nowadays. And sometimes people say they're doing DBT and they're not actually doing DBT. So we're going to talk about a little bit about what it is. And then from there, we'll go into what it's not, how it was developed, who it is best for. And hopefully I'll have time to teach you a little bit about some of the main principles. So DBT is a therapeutic program. It's designed to be both comprehensive and flexible. By which I mean the idea is to keep people in their lives, not put them in some kind of treatment facility. So DBT is designed to go into your day-to-day life and be there for you while, for teenagers, they're attempting to go to school, to work a job, to have their family relationships. But it's also designed to be flexible, to be tailored to the individual. It's a principle-based treatment, by which I mean it has these overarching principles that clinicians are following that they share with both clients and families, but it isn't a protocol-based program. So most empirically supported psychotherapies that were available prior to the 1990s were protocol-based, meaning that if you went to see someone, say, for panic disorder, session 1 looks like this, session 2 looks like this, session 3 looks like this. DBT was the first treatment to have these broader principles, meaning that session 4 might look very different from one client to another based on what that particular client needs, but you could still say that the clinician is using the same principles, and that's how we decide whether or not something is DBT. It's also designed to be time limited. So it's generally between 6 and 12 months is the course of treatment in DBT. A question I get all the time is what's the difference between DBT and cognitive behavioral therapy? CBT, or cognitive behavioral therapy, is a really large umbrella under which many different treatments fall, and DBT is a very specialized form of CBT. So they're actually not different, but if you look at the diagram, there's a big circle of CBT, and DBT is one part of it. It's what's called a third wave behavior therapy, which is what came after a few other types. If you've heard of acceptance and commitment therapy, or ACT, that's another third wave behavior therapy, but DBT was the first one. And what makes it different from standard CBT is that it integrates dialectical philosophy, which we'll be talking about, and some practices from Zen mindfulness in terms of ways to manage emotions that aren't strictly related to thoughts and behaviors. DBT was also the first empirically supported treatment that was designed for multi-diagnostic patients. So what I mean by that is most other treatments, when they were studied, they would have, researchers would exclude people that didn't have the one diagnosis that the treatment was meant to study. So if it was a treatment for depression, it had to be your first depressive episode, and you couldn't also have anxiety. You couldn't also have ADHD. DBT was designed to be for anybody with whatever symptoms, as long as you could participate in the program. So it turned out what most people had was challenges regulating emotion, but that's a symptom that can cut across a lot of different diagnoses. So it's less my child or I have this diagnosis, therefore DBT, and more, do you have challenges in regulating emotion, which we're going to get a lot more into? Do you have big emotions? Are they getting in your way? If so, DBT is probably a good treatment for you. But it doesn't have rule outs in the same way that other treatments might, and say, oh, well, if you have this, you can't benefit from DBT. So what do I mean by emotional dysregulation? We will get to that, I promise. What DBT is not. So prior to DBT, when it was first studied in the late 1980s, there were a lot of suicide prevention programs. A criticism of these was that they made people stay safe and not hurt themselves, but they didn't actually target the reasons that they wanted to hurt themselves. So Marsha Linehan, who was the creator of DBT, who I'll talk a little bit more about in a moment, was very adamant that my goal is not to keep people alive and to stay miserable. My goal is to actually help them change the things that are making them feel suicidal in the first place. It's not only a skills training program. The skills are very famous in DBT, and you'll see DBT skills being taught in a lot of different places. And the skills are great, but that's not the only part, that's not the only piece of DBT. And it's also not a way to make people with big emotions behave. So sometimes if people have a partner or a child that's struggling with big emotions, they kind of want DBT to fix them. DBT is really focused on the autonomy of the person and on their specific goals and helping them achieve their specific goals, which is why we say the goal of DBT is to build a life worth living. So the assumption is if someone is feeling suicidal, if someone is engaging in self-harming behavior, it's because what's happening in their current life now is not working for them. And DBT is designed to help them build a life that they want to stick around for, that they feel good about. So that's our big goal. So time for a little story. This is a young Marsha Linehan in the 1980s. She, some of you may know already, there's a great New York Times article from a few years ago where she sort of came out and said publicly that she had had a great deal of challenge when she was a teen and a young adult with feeling suicidal, with harming herself. She spent a great deal of time in an inpatient unit. And when she came out of all of that, she became a research psychologist, and she wanted to help the people that were suffering the most, that weren't being helped by the treatments we had at the time. And those were sort of standard CBT. Also, psychoanalysis was still quite popular, and there were many medications, none of which were helping the people with really chronic emotional dysregulation that were going in and out of hospitals that Marsha wanted to help. So she came to work at a facility in Washington State where there were women in their 40s, 50s, and 60s who had been hospitalized for months and months, some of them years, and who had tried to take their own lives multiple times. And she had studied all of the latest in CBT behavioral interventions and really felt like she had skills that would help these women tolerate distress better, regulate their emotions better. And she kind of came in and said, I know what you need to do. We're going to change your behaviors. You're going to do X, Y, and Z differently. And they got really mad at her. And they said, hey, I don't know who you are, lady, but if you think I can just do X, Y, and Z, you're not listening to how hard my life is. You're not hearing all the things I've been through. If I could do things differently, I would have already done that. This isn't helpful. So she went back to the drawing board. She had been very change focused. She'd been very focused on thinking about how she could get people to do something differently and realized she needed to listen more. So she went back to the drawing board and studied a bunch of different therapies, Carl Rogers, client-centered therapy, feminist therapy, a lot of things that were very focused on listening and reflecting and understanding. And she went back to these women and said, I hear you. I hear how challenging your life has been. What an awful thing to go through. I'm so impressed that you're still here. I understand what you're going through. And they got just as angry as her. And they said, if you understand how bad my life is, why aren't you helping me change? I can't keep living like this. And this is where she hit upon the idea of a dialectic, and of the dialectic being two things that seem like opposites can both be true at the same time, specifically that we need to balance acceptance and change. So the dialectic and dialectical behavior therapy, anything that seems opposing that somehow we can hold simultaneously. Acceptance and change being our central one, but things can be both structured and unstructured. They can be hierarchical and egalitarian, and we really strive to believe both sides of the dialectic simultaneously. So when someone has a really hard time regulating their emotions, they often see things in very black and white ways and can't really see things more broadly and in a more open way. So this was her idea, and specifically this idea of accepting, wow, I can really hear your story. I can see where you're coming from. I can see how challenging this is for you. And at the same time, I can see you don't want to stay here and we need to do something differently. How can I help you change? How can I help you move forward? And holding both of those things simultaneously, that a therapy that was only accepting would not actually help these people build a life worth living, but a therapy that was only change oriented, she wouldn't be able to gain enough trust that people wouldn't believe that it was going to be helpful if she didn't understand how bad it was in the first place. So this is where we get our core dialectic. And in DBT, we're always trying to balance acceptance and change. So there are some skills like mindfulness, like distress tolerance, that are really focused on acceptance. And there are some skills like interpersonal effectiveness or emotion regulation that are really focused on change. And in any given moment, an interaction, a DBT therapist with a client is trying to both really understand where they're coming from and push the client to do something different. Believe that they're doing the best they can and that they need to do things differently and be more motivated to change. And this was kind of the genius synthesis that she came to, of trying to really prioritize both of these things in order to come to a good outcome, because traditional therapies had really been one or the other. So who benefits from DBT? Again, it's this large umbrella of people with big emotions that lead to problem behaviors. And we're going to talk about that a little bit more, what we mean about that in a second. Their loved ones and caregivers can also benefit. So there's DBT couples therapies and there's DBT family therapy that we do with teens and young adults. And there are over 50 randomized controlled trials. That's sort of the gold standard in psychotherapy research, showing the effectiveness of DBT, particularly for strong emotions, for suicidal behavior, for self-harming behavior, and other dangerous impulsive behaviors, substance use, risky sexual behavior, sometimes physical aggression, things like that. So it's less about a specific diagnosis and more about this pattern of problems where the emotions are overwhelming and leading to challenges. So the biosocial theory is how we understand how these things develop in DBT. And I chose to teach you all this today because I think it's very helpful for keeping empathy for people who are suffering because of big emotions and for understanding where it can come from. And DBT is designed to both help loved ones understand that and also help the individual person understand it. So one thing that we know is that people who have big emotions tend to just start out that way. So this is a graph. The y-axis is intensity of emotion, and the x-axis down at the bottom here is time. And I'll start with something irritating happens in your day. Trying to think of what happened to me. Oh, earlier today, I was getting dinner ready so I can have it with my kids when I'm done with this talk, and the fire alarm went off while I was like browning the thing that I was making. So I knew there wasn't actually a fire, but it's still a really loud noise. It's very frustrating. So my emotions started to go up, and then slowly over time they came back down as the fire alarm shut off and as the extra smoke cleared, and I got the back door open and got a little smoke out, and my dog stopped barking in addition, right? So most people, about 90% of people, have some kind of pattern similar to this, where an event happens that causes an emotion, your emotion goes up and it comes back down again. This is an average. So some people have a big reaction right away and then it gets easier. Some people stew for a little while and then get upset and then it comes back down. But this is around average for about 90% of people. Now, 1 in 10 people have what we call a biological vulnerability to emotions, where their emotions are just a lot bigger than the average person. And as far as we can tell, in the 90s, Marshall Linehan just hypothesized that this was the case, but brain research appears to back it up, that some people are born more sensitive than other people. So the same thing might happen. You're making dinner and the fire alarm goes off, the smoke detector goes off. And instead of gradually getting upset, you get upset right away, and you stay way higher, you get much more upset, and it takes longer to come back down. So these are the characteristics of this biological vulnerability to emotion. It's high sensitivity. How quickly do you react to an emotional stimuli? High reactivity. How high does it go? So does it come up just to 20 or does it go all the way to 80 or even higher? And a slow return to baseline. How long does it take before it comes back down again? And these are things that my clients, the teens that I work with at UCSF, all really feel a kinship with. And their parents say, oh, yes, this is my kid. And when my kid was really little, I could tell that they had these big emotions. Not everybody starts out this way that develops emotion dysregulation, but a high proportion of people do. And this in and of itself is not necessarily a problem. Having big emotions can make you good at a lot of things. You can be a good therapist, for example. You could be a great artist. You can be a good writer. There's a lot of things that it can be helpful for in managing people and understanding others. And about 10% of the time of this 10%, it gets stickier than that and can cause additional problems. So we're going to talk a little bit about that. But we'll unpack this high sensitivity, those quick reactions with only a little bit of provocation. So something that seems like a really small thing to one person could get a really big reaction from someone that has this high sensitivity. The extreme reactions, how quickly it happens. And when you're up there at this 80, it makes it really hard to think clearly. Your emotions are kind of front of mind. They're right in front of your face, and you can't really do the things you need to do day to day. So that makes it really hard. And then the slow return to baseline means that you have this long-lasting reaction and you're much more sensitive to the next emotional event. So if we look at someone's day, if we look at this point in time, I'm already almost done with my emotion, right? Of my irritation and my stress from the smoke detector. This person's still at the height of their emotion. So if something else happens then, someone calls with bad news or they stub their toe, anything, it can send them even higher and make it much harder to deal with the next thing that causes some emotional activation. So understanding this can help a lot, that this is just something we all process emotions differently. Now, just as there's about 10% of the population that has this pattern, there's probably about 10% of the population that's just very unemotional. And it turns out sometimes people are in the same family have those two categories. And so it can make it really hard to understand why someone is having such an emotional response if it's not how you tend to process emotions. Where this really gets into trouble is when it's coupled with what's called an invalidating environment. I'm going to read the definition, and I'm going to talk a little bit more about it. So in an invalidating environment, an individual's thoughts and feelings are met by unpredictable and extreme responses from family, friends, teachers, and bosses. An individual is led to believe that they are wrong to have those thoughts and feelings. And I want to be really clear that this invalidation occurs on a spectrum. So there's some things that are really, really invalidating and some things that are very small invalidating. I'll give you examples of both, but they can still have an effect on this biological vulnerability. So I have two daughters. I believe my older daughter has a biological vulnerability to emotion, and my younger daughter does not. So the extent to which one of them is invalidated is very different because she just has bigger emotions. So I don't mean this as a spoiler, but the movie came out a very long time ago. If you've seen Bambi, the Disney movie Bambi, the mother deer gets killed in the beginning, right? And a very normal response to a small child being upset about the mother deer being killed would be to say, hey, don't worry, it's just a movie. It's not a real deer. It's no big deal. It's fine. Okay. If you say that kind of thing to my younger daughter, she's like, oh, okay. And she goes off and, kicks the ball around again. She's totally fine. But if you're a kid like my older daughter, like some of your children, who has really, really big emotions, and you have just seen this very beautiful rendition of a cartoon deer get gunned down by a hunter, and you're feeling really sad and scared for Bambi and his upset at losing his mother, and someone says, it's just a movie, it's no big deal, you can be left questioning your own experience and wondering what's wrong with you that you're having these big emotions when your little sister is fine and can just move along from it. That's what I mean by a simple form of invalidation. So sometimes just questioning, just saying like, hey, it's no big deal, don't worry about it. Oftentimes as parents, we want to reassure our kids. We want to make them feel better. We want to solve the problem. We want to fix the emotion. And sometimes if the emotion feels really big to the kid already, that can be invalidating. On the other side of the spectrum are very serious things. Physical or sexual abuse are very clearly invalidating. They're very clearly communicating that individual's thoughts and feelings don't matter. And we see the whole spectrum in our program, but I'll say it's really common that it's this well-intended form of invalidation that's just trying to solve the problem and help a kid through an emotion that can still have a big impact. So when this biological vulnerability is coupled with this invalidation, it can lead to problems because these two things cycle with each other. So when you have a biological vulnerability to emotion, you're more likely to get invalidated by your environment because the other people around you are less likely to experience emotions the way you do because it's only 1 in 10 people who have those big emotions. And so they're going to be confused and they're going to say, why are you so upset? I don't understand, right? But because our emotions are meant to communicate with other people and help us connect with other people and help us understand our environment and our world, when they are shut down like that, when they're not met with validation, they tend to increase. And so that's what this arrow going back up is. When we get invalidation, it tends to increase that biological vulnerability because our emotions want to be heard. Shutting them down doesn't work. It doesn't make them stop. And so then they get bigger and you're actually more likely to get invalidated the bigger emotion because again, there's fewer people that are having that big emotion, which leads you to be more vulnerable over time. So this cycle can start very early and it's not really anybody's fault because again, that person has a 1 in 10 response to emotional stimuli. So it makes sense that other people aren't experiencing the world the way that they are. But when it gets shut down, even when it's well-intentioned, it can increase. And this over time can lead to behavior problems. Whether it's something mild, like, I don't understand why you're so upset, to something more serious, like, you're so stupid. So this can cycle over time, even if it's, why are you being so dramatic, into these behavior problems that we often see when people have challenges regulating emotion. So this can be confusion about who you are and where you belong in the world, interpersonal problems and challenges because our emotions have a lot to do with how we interact with other people and how we understand ourselves in the world, can lead to impulsive behaviors. Because if you remember that chart, when you're way at the top, you want that emotion to stop. And so you'll kind of do anything to bring it back down again. And that can include self-harming behavior, stealing, risky sexual interactions, all kind of things that people are trying just to make the emotion go down and try to make the emotion stop. And that, of course, leads in time to more emotional instability and questioning of your own emotional responses. So this is kind of who the ideal DBT patient is someone that's having these challenges because of that baseline difficulty with emotions of just having bigger emotions than the average person, and then has experienced some kind of invalidation from the environment. Another really important thing for me to mention about the invalidating environment is that it also happens not just on a spectrum individually, but there are concentric circles of invalidation that can happen in the world. So I live in the Bay Area. I commute on BART to work. I don't know how many people on this webinar have cried while on a BART train. I don't recommend it. People move away from you, right? People don't say, "Oh no, are you okay? What's going on?" We as a society don't really love to talk about emotions. We like to watch them on television or maybe behind closed doors with individual people. But there's a lot of invalidation that happens. And then, of course, there's also invalidation that happens related to our status in the world, whether it's racism, whether it's poverty, whether it's immigration status. There's lots of other ways that we can be told that we're not okay or that our emotions are wrong. So we're not looking for like a source of invalidation and saying that invalidation is the problem. The benefit of doing DBT with families is that we can teach validation and how to help, because ultimately the goal is for people to be able to validate themselves and say, hey, my emotion makes sense. It's true for me, and that's okay. But often we learn that from our closest people. So that's sort of the goal of understanding the biosocial theory. Knowing that this is sort of our ideal person, regardless of what specific diagnoses are attached to them, talk a little bit about what is actually offered in DBT. So DBT has several modes of treatment, by which I mean the different ways in which it's delivered. And this is for what's called comprehensive DBT, which is what is studied the most in the literature for DBT. So a lot of places will do what I call DBT-informed therapy, where you might have just an individual therapist who knows some DBT, who's weaving DBT into their individual therapy. That's not what I'm talking about now. I'm talking about what's been studied the most in the literature. And this is what we offer at UCSF, but there are other places that offer it as well. So one is that there's a skills training group. So while we believe that people are doing the best we can, we also believe that they need skills to approach their emotions differently. And the skills training group is designed to impart a bunch of different skills to help the people involved. And in the case of teens, it's the whole family, learn different skills to regulate emotions, tolerate distress, manage interpersonal conversations, apply mindfulness to everyday life and your emotions. And there's a module called Middle Path, which is designed for parent-teen conflict. So every week in our program, teens and parents come together 2 hours, one evening a week, to learn these skills. Everybody gets their own binder, everybody has homework, and across the course of 6 months, you learn the skills. In addition, DBT has individual psychotherapy with the teen. That is a talk therapy, as Chi-Ching mentioned, that is structured. So there's something called a treatment hierarchy. We're making sure we're addressing the things that are most important. So if someone has suicidal ideation, if someone is engaging in self-harming behavior, that's going to be the first thing that we talk about each week. The individual client will also keep a diary card to note their emotions, their different behaviors throughout the week. And then often this also includes family work. And that's also another component when you're talking about teens and young adults is family therapy, helping the individuals in the family understand the emotions of the identified patient, and also helping everyone learn the skills together and apply them in their individual circumstance. So the skills training group is to get the skills in for both the teen or the young adult and the parents, and the family therapy and the individual therapy is to pull them out and address them for their specific circumstances. In addition, DBT offers something called skills coaching, which means that my patients that I carry have my cell phone number, and they can call me 24 hours a day, 7 days a week if they need help using their skills. Now, you'll notice I'm not interrupting this talk to answer a coaching call, so I'm not available immediately, but I do call back. And the idea behind that is that it's one thing to learn a skill in a classroom when you're feeling kind of okay, and it's another thing entirely to apply the skills when you're emotionally dysregulated and things are really, really challenging. So it's a 5 to 10 minute call that's designed to help in the moment apply those skills. And then parents in our program also receive coaching, not 24 hours a day, but every day, 7 a.m. to 10 p.m. to help them use their skills. So the things here on the left side of my slide are what's included in comprehensive DBT. Another thing that's included that you won't see on the right-hand side is our consultation team. So that is designed to provide therapy and support for the therapist to make sure they are doing DBT as inherently as possible, because we want to be giving what we're promising, because we know that has the best data behind it. And also to provide support, because all of the clients we're working with have these big emotions and most struggle with suicide and self-harm. And then everything else that someone might be getting, whether it's work with a psychiatrist or case management, school interventions. In DBT, we just call those uncontrolled services. It's nothing bad about it. It's just not part of DBT, but those are things that someone might be engaging with while they're in DBT. So these modes are designed to address these functions. So this is, what are we actually trying to do in DBT? We're trying to get everybody skilled up, the teen and the parents alike. We want them to learn skills that can help them address things differently in the family. We also want to be continually improving motivation. This is one of the innovations that Dr. Marsha Linehan, who created the program, added in that was different from other therapies at the time that I'm really impressed by. It's really normal for motivation to go up and down for therapy. Therapy is hard work. Being depressed, having a hard time is also hard work, but therapy is very hard work. And when you're a teenager, it makes sense to want to do lots of things, but maybe not spend a ton of time in therapy. And even for parents, it makes sense that motivation goes up and down across the course of therapy. So one of the functions, the way the different modes are addressed, is to help improve this motivation. We also want assured generalization to the natural environment. That is a fancy way of saying making sure you can use the skills we're learning here where you actually need them. So that's what the coaching is for. But it's also what planned practice is for. We do a lot of role playing in session. We do a lot of practicing of like, okay, this is a hard conversation that you're going to have with your teacher or your boyfriend. Let's do it right now. What skills are you going to need? How can we make sure that this is likely to be a success for you? And then the consultation team is designed to enhance our capabilities and motivation as therapists to help us keep going. We also want to help structure the environment. So we know that as an example, one of the biggest interventions to help suicidal teens is what's called means restriction, which is basically making sure that they don't have easy access to things that they could use to harm themselves or kill themselves. That's one example of structuring the environment. So working closely with parents to make sure those things are locked away or not easily accessible, because anything we can do to increase the amount of time is helpful. This could also be structuring the environment by helping the individual teen tell people what they need. So expressing themselves more directly, asking for what they want so that the environment is more able to support them. And then we want to decrease invalidation where we can and increase effectiveness in the environment. The world is invalidating. We're not going to get rid of all invalidation, but we want to teach people to be able to validate themselves and also teach them to be able to shape their environment to be more likely to be validating to them as well. So those are our goals. We address these functions through these modes that I just mentioned. So what are these? This is what we're trying to increase in DBT on the left, and here are the behaviors that we're trying to decrease on the right. So all of these are addressed through the different skills modules. And again, those are available in lots of places. DBT skills have become very trendy. They're not hard to learn in and of themselves. And there's a lot of skills, DBT skills available on the internet. I mentioned a few different things in the end of this talk. There's also Rutgers University has a series of videos on YouTube, so maybe we can link that from the description of this on the YouTube page for Alan Hu Foundation that give little 5-minute descriptions of the skills that are all very accurate. So if your teen is not really having a hard time, if you just notice that they have big emotions and things haven't gotten really bad yet, learning some of the skills on their own can be really helpful. The comprehensive program is really designed for people that the problem behaviors that we mentioned, these behaviors to decrease, have really gotten out of control and gotten to a point where it's getting in the way of their basic developmental tasks. And that can make it really challenging to live their life and build a life worth living. And so in order to address that, these skills do so. Core mindfulness, I just wanted to mention a little bit more about, because that's a very central skill in DBT. We call it core mindfulness because without using mindfulness, it's hard to access any of the other skills. So I'm just going to skip ahead for a minute because and then I'll come back because I want to talk a little bit about this idea. So Marshall Linehan studied different mindfulness traditions around the world. Almost every culture has a practice of mindfulness or meditation. And she wanted to make it, some of them can, traditional ones that many people know of can have a little bit of a high barrier to entry for people with really big emotions. So she wanted to make them bite size so that when people are really desperate, they can use a little bit of it here and there and try to then, broaden it out over time to actually being able to sit mindfully and contemplate things for a longer period of time, which most people suffering from chronic emotional dysregulation cannot do. And she came upon this heuristic of the states of mind. So that when one is in emotion mind, for instance, that's when emotions are our facts. And all we're thinking about is emotions. And so we're making our decisions from our emotions. So it tends to be impulsive, it tends to be hot, and we're not really thinking of the long term. We're thinking of what's going to be helpful right now. When we're in reasonable mind, facts are our facts. There aren't any emotions at all. You might be doing a math problem. You might be solving some kind of equation, doing something very mindful, like that doesn't require any emotions from you. Or for me, it's brushing my teeth. I don't have big emotions in either direction about brushing my teeth. I brush my teeth so that I can avoid having a big dental bill later. It's a thing I do for fact reasons. I know it's good for my overall health. I'm not excited to do it. I'm not upset to do it. I'm just doing it because it's a part of my routine. What we're going for when we're trying to understand our emotions and trying to decide whether or not we should engage in different behaviors is what's called wise mind. And wise mind is really the synthesis of emotion mind and reasonable mind. It's where your emotions are important, but at the same time, you can think about your long-term goals. So if somebody's engaging in a dangerous behavior because their emotions are really big, that's usually going to occur in emotion mind because they're not thinking about the long-term reasons that that's not going to be helpful. And so we want to help people learn to notice when they're in emotion mind, and then we have specific skills to help them try to get to wise mind, to try to get to a place where they can still understand and validate their emotions, but they don't have to act on them immediately. So the slightly cheeky example I often give in my skills class is if I am a person who really loves dogs and I go to the animal shelter to volunteer and there's a new litter of puppies there, there's like 7 puppies and they're the cutest puppies I've ever seen in my life. If I go in emotion mind, I'm going to adopt all 7 puppies because all that matters is that they're the cutest puppies I've ever seen in my life. But if I go in reasonable mind, I don't live on a farm. I live in the Bay Area. It's really expensive here. I'm not going to adopt any puppies. There's no reason to have a puppy in reasonable mind. There's no fact-based. I don't have like a sled team. I don't have a cat problem. There's no reasonable mind reason to adopt any puppies. But if I go in wise mind, it's important that I love this litter of puppies, and it's important that I have limited funds and limited time. So maybe I'm going to adopt 1 puppy or maybe 2 if I'm really lucky, right? But I'm not going to get 0 and I'm not going to get all of them. So just starting to notice, when are you in emotion mind? What are your signs that you're in emotion mind is one of the first skills that we teach to help people understand, how do you know that maybe you're not making the best decisions? How do you know that maybe you're not considering everything? But we also we're not trying to promote reasonable mind either, as like, let's be robots and let's just analyze things. We want to make sure that people are considering their emotions because their emotions are important and they tell them big things about themselves, but not feeling overwhelmed by them. So that's just one example of where we start with mindfulness. And that leads us to the ability to use all the other skills. Because if I can recognize I'm in emotion mind, then I can recognize that I might need to do something to change it. I'm mindful of time, and I know we have questions to get to. So I want to say just a couple other things about what treatment do you actually choose. So what I've been describing, and I've hinted at this a little bit, I've been describing comprehensive DBT. Comprehensive DBT is usually what you want if your kid has Certainly, if you or your child has already made a suicide attempt, has been in and out of psychiatric hospitalization, then comprehensive DBT has the best chance to help them learn all the skills, help them internalize and generalize the skills. If you got a kid that has big emotions and sometimes it flares up, but sometimes it doesn't, it's not necessarily causing them a huge problem. It hasn't led to suicidal behavior or anything like that. DBT-informed treatment can be great. So that could be a skills group on its own, or it could be a therapist that knows DBT that's going to integrate the skills into their regular talk therapy, or even do sort of DBT-based individual therapy, but it's not the whole comprehensive program. That works great for a lot of people. You don't necessarily need the whole thing if that's not the central problem that you're working on. And then there is a DBT Linehan Board of Certification that was mentioned at the beginning of the teaching, mentioned at the beginning of the talk. So this is an organization that is trying to help the public by noting what programs have all the components required to really call it comprehensive DBT. So if you feel like you are in a situation or someone has recommended, hey, you really need real DBT, you want to make sure that you're getting the whole deal, you're getting all of the parts of the treatment because this person has really had a hard time and has been in and out of higher levels of care, then you might want to look for a DBT Linehan Board certified program. I will be direct and clear that unfortunately a lot of these programs are in private practices, and many of them, at least where we are locally in the Bay Area, don't take insurance. Many other states, they do take insurance. And the board, the DBT LBC board, they have an easy to find website, is also great at helping provide referrals and giving you ideas of people to talk to if you can't find a program near you. Our program takes insurance. We work to provide insurance programs that take insurance in county programs, but sometimes that's harder to find, and sometimes it's easier to find a DBT-informed therapist. So with more mild symptoms, that's absolutely something that would be helpful. And then to close before questions, I have a bunch of resources here. One that I want to highlight that because I mentioned means restriction, UCLA has put together this wonderful website that is literally a question and answer that you walk through as a family member of someone who struggled with suicidality to make your home as safe as possible and to give you information about means restriction and getting dangerous things away from that person. So I highly, highly recommend that site. There's a summary of all the research evidence for DBT here at this website. I didn't mention borderline personality disorder directly in my talk. That is often what people are diagnosed with who have really big challenges with emotion regulation, although emotion regulation can also be a challenge in depression, in ADHD, in bipolar disorder, in autism. So there's lots of other places where it shows up. But if you or your child has been diagnosed with borderline personality disorder or children that you work with, there's great references here, both at BPD Central and at borderlinepersonalitydisorder.org. And I believe that I am right on time at 7:15. So thank you very much, and I'm happy to answer questions.
Thank you very much, Dr. Shaller, for sharing your very nice and useful information about DBT. Now we open up for Q&A. So the first question is, can DBT also be helpful for people who don't necessarily consider themselves as having strong emotion, but easily overwhelmed by things that others would be considered part of a day-to-day life?
Oh, that's a great question. Yes and no. So I'll say one of the things that I appreciate about DBT but that can be a little scary for parents that are worried about their teens or young adults is that DBT is defined as what's called a treatment of choice. And what that means is the person doing DBT has to want to do DBT. So there's a process where you start DBT that's called orientation and commitment. So before you get into the group, before you really start the meat of the work, before you do any family therapy, you would meet with the therapist for 4 to 6 times, both to do an assessment, but also to learn, hey, let me tell you a little bit about what DBT is. Let me tell you why, based on my assessment, I think it would be good for you. But also for the client in that case gets to give me a test drive and see, hey, does this seem like this is something that would be helpful and something that I would be willing to try? Now, I'll say skilled DBT therapists are very good at getting people with like the challenge that you mentioned, who maybe do have big emotions but don't notice that they have big emotions, to see some of the places where they don't have big emotions. But so we use what's called motivational interviewing and commitment strategies to get people to agree to do the longer course of treatment, which again is 6 to 12 months. That said, if someone is really like, this isn't my problem, I don't want to do this, DBT is probably not the right place for them. But I would
Okay.
say that's true for most treatments. Other treatments will say they'll take you if you don't want to, but there's a lot of evidence that if people are totally against a particular psychotherapy, it's probably not going to be very helpful to them, which is why I think Marshall Linehan included that as a requirement that people have to want to do DBT.
Okay. And next question, can trauma and PTSD also be a trigger to high emotional responses and become a lifelong thing for them?
Absolutely. So trauma is one of our biggest invalidating environments. So in fact, when people first identified borderline personality disorder, or when Marshall Linehan was first starting to do DBT, in the 80s and 90s, people thought that 100% of people that could benefit from DBT probably had a serious traumatic event or met criteria for PTSD. We know now that it's not 100%, it's closer to 35 or 40%, but it's a very common pathway to having dysregulated emotions. But not everybody has it. And that's actually a reason that sometimes delays treatment for people that don't have a very traumatic background. Because if you have a big enough biological vulnerability, you can develop those symptoms even without a serious trauma. But sometimes the symptoms are so big, people think, well, this person must have a very big trauma in their background. And when they don't have a trauma, it's like, well, maybe she'll grow out of it, or maybe she'll feel differently. But trauma definitely plays a big role for a plurality of our patients.
Okay. Next question, can DBT be effective for people with autism spectrum disorders or intellectual disabilities?
Yeah, so there's a woman named Julie Brown who, I'll answer the intellectual disabilities first and then go back to autism. So for intellectual abilities, Julie Brown created what's called the DBT skills system that's designed that made the skills simpler and broke them down for people with intellectual disabilities. So I'm not super familiar with that because it's not what we specialize in our program, but it is out there. With autism, I think, well, there's a joke among DBT therapists that the answer to every question is it depends. So I'll say it depends with autism. We do have many clients with autism spectrum disorder in our program. And it's really, I would say, if the primary and only thing going on is autism, there are adaptations. Amara Brooke is a psychologist and also Lori Ritchell, who've done a lot of work on doing DBT with autism, but it's not designed for the autism. It's to address the emotion dysregulation that comes with autism. And so it doesn't, teach social skills or adaptive living skills or things like that. But if someone has big challenges with emotion regulation, also happens to be autistic, DBT can absolutely be helpful.
Okay. Oh, Dr. Shaller, can you stop sharing the screen so we can
Oh,
see a bigger screen of you?
yes, sure. Hi.
Great. Hi. Okay, so the audience asked the question about, can DBT help with anxiety and the OCD?
Yeah, so DBT is designed to integrate, like one of our charges, one of our goals as DBT therapists is to integrate whatever evidence-based treatment is needed for the multi-diagnostic patients that, as I mentioned at the beginning. So if someone comes to us and they have really big challenges regulating emotions and they also have OCD, I'm going to do DBT, but I'm also going to integrate exposure and response prevention, which is the specific CBT that is made for OCD, into the DBT. So if someone only had OCD and didn't have other challenges regulating emotion, I wouldn't recommend DBT. I would recommend CBT and exposure and response prevention. If they also were suicidal and or super emotionally dysregulated, absolutely we can integrate OCD treatment into the DBT. And it would be about sort of triaging and planning on the hierarchy, what do we address when? So we might not spend a lot of time on the OCD initially if there's also depression and suicidal thinking, but then eventually we would work our way down to also address the OCD.
Okay. The next question, is DBT also effective for adults, or is it most effective for adolescents and young adults?
Yeah, so there's way more data on DBT for adults. It started as a treatment for adults. That's just not what I do. I'm in the Department of Child and Adolescent Psychiatry at UCSF. So it was a treatment for adults first, and there's way more of those randomized controlled trials are on adults than on teens. So the main difference with adults is that it's an adult skills group. It's not multifamily format. It's just the patient that's there. And you may or may not do any couples or family therapy. It may only be the individual therapy, but it absolutely has a ton of data behind it for adults.
Okay. Oh, there's another question. And can you please open the resource page again?
Yes.
Yeah. But just for audience information, this webinar is being recorded, and the recordings
Yes.
will be
You can
shared
come
in,
back to it.
yeah, and come back. And the recording will be shared in the Alan Hu Foundation website and the Alan Hu Foundation YouTube channel in about 2 weeks. Yeah. Okay. The next question, what are some good conversation starters for younger students in the elementary school, such as fourth or fifth graders?
Conversation starters about
Starters,
emotions or
um, not very clear.
okay. Well, I'll do my best. I think there are a number of social emotional learning curricula out there that have sort of developmentally appropriate DBT skills-based ideas in them. So the one that was at my daughter's elementary school was called the Toolbox Project. And it was
Mhm.
really about using mindfulness and understanding your emotions. I think the most important thing with kids is just helping them understand that emotions don't last forever. Everybody has them, and it's okay to be an emotional person. And so, if that's what you're asking about, um, you know, talking about everybody has emotions, how do you understand your emotions, looking at an emotion wheel, or thinking about how do you understand different emotions in different moments? How do you know how someone else is having an emotion? The movies Inside Out and Inside Out 2 are fabulous. They're all based on really good emotion research, so which is not a thing I usually say about psychology in the media. So those can also be really good conversation starters to understand, who's in control and what emotion is steering the ship at that point.
Okay, great. The next question, how does DBT work on black and white thinking when the person is unable to talk about or understand emotions?
Yeah, so there's a lot of work on talking about and understanding emotions. One of the things that I really love about DBT is the skills group because it's really like a community college level class on emotion theory. And so we're really trying to help people understand their emotions and understand where they're coming from and understand the purpose, like why do we have them evolutionarily? Like what is the purpose of shame? It's not always bad. We have it for a reason. What is the purpose of anger? How does it motivate us? And what does it do to help us understand our world and connect our world and be effective in our world? And so there's a lot of education that's involved in DBT to get to that point of understanding that. But the other place that helps is this idea of dialectical thinking and dialectical philosophy. So working to notice our judgments, notice when we're only looking at one side of a problem, and try to think about how can we look at the bigger picture, how can we identify what the other side of the dialectic is in order to start to see more of the grays in life. And it's really challenging. And I would say back to my answer to a previous question, if someone doesn't at all identify as an emotional person, if they're like, no, the problem's with someone else, I don't have emotions at all, then DBT is probably not the right treatment. It's really for people that have felt like they're too emotional and a lot has gotten that message over and over again and want to understand it better.
Okay. Next question, are there programs available for children 11-year-old?
So the DBT, so there is something called DBTC, DBT for children. The research on it is kind of it's not great. Sometimes I think it's getting a lot better. But there are programs that specialize in like tween age, and then there are programs with younger people as well. So you just have to kind of Google around and look. Some programs that specialize in teens will have sort of a middle school group specifically. I find that younger teens have a hard time with some of the concepts, and also in terms of like full comprehensive DBT with all of the parts, a lot of times if you're only like 11 or 12, you may not be that motivated to work on stuff because you just haven't been suffering that long because your life is not that long. So sometimes it takes a little bit of perspective for a teen to say, well, I tried these other things. I tried some kind of regular talk therapy. I tried other things for a couple of years and it hasn't worked. And I guess I need to do something different. So a lot of times our program starts at 13 because 11 and 12-year-olds just aren't really ready to look at that stuff. But what can be really helpful is work for the parents. So sometimes you don't need the kid to be in therapy. You need the parents to understand more about their own emotions, what they might be accidentally reinforcing in the kid, how they can work to keep the kid safe, how they can foster the kid understanding their emotions. And so finding a parent group or finding a family therapist that's willing to work with parents, even if the kid is not into it, can be really, really helpful, even if the kid doesn't attend treatment themselves.
Okay. And how much of emotional dysregulation is genetic?
Yeah, I mean, we think of a fair amount. So this is something that's still being studied. There's a lot of researchers looking at this. But I will say clinically, anecdotally, most of the people, probably 75% of the people that come to my program say, oh yeah, we could tell when this kid was tiny that they just had bigger emotions than the average person. And that doesn't mean that the parents necessarily have big emotions, though often one of them does, and maybe the other one doesn't and doesn't understand what's happening. But we do think there's a genetic component. I mean, most mental health challenges, there's some genetic component, but psychology is still very young, and so we don't understand all of the mechanisms. But we certainly do think there's a big genetic component. And that's kind of what we think of with that biological piece of the biosocial theory.
Okay. Next question, what can a board-certified behavior analyst or special education teacher do to utilize DBT skills to help students who have a suicide ideology? What resources are there they can use?
Yeah, I mean, I think the skills training books for the DBT skills for teens book that's available by Miller, Rathis, and Linehan is great and has a lot of teaching tips in it. There's also DBT in schools. If you go to dbtinschools.org, there's an educational psychologist, Jim Mazza, who worked with his wife, Liz Dexter Mazza, who is a DBT therapist, to create a social emotional curriculum for middle schools. And that can be used to help kind of everybody learn more skills and learn about their emotions. I don't want to give specific advice for a specific child with suicidal ideation, but that would be where I would start in terms of learning those skills.
Okay. Dr. Shaller, I think we are about time to stop. And thank you for sharing your knowledge about DBT with us today.
Absolutely. It was my pleasure. Thank you so much. And, thank you for all the work you're doing. Congrats again on getting Nonprofit of the Year. I think,
Thank you.
everything you're doing is wonderful. So I'm honored and proud to be among the pantheon of Alan Hu lecturers.
Oh, thank you so much.
All right. Take care. Good night, everybody.
All right. Thank you. And thanks everyone for joining our webinar. And we hope to see you again in the next webinar. This webinar is being recorded and recordings will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about 2 weeks. And please subscribe to Alan Hu Foundation YouTube channel. And please take a moment to fill out a short survey. Your input is critical for us to improve our program. And I will leave the donation QR code for a few more minutes. And thank you for donating to support our programs. With that, I'm closing this webinar. Thank you, everybody. Thanks, Dr. Shaller.
Bye.
Bye.